Welcome to Kids Doc Talk with Dr. Jennie. Dr. Jennie is a board-certified pediatrician and is the Director of Telemedicine at Pediatric Associates.
Welcome to Kids Doc Talk with Dr. Jennie. Today's guest is David Orozco, talking about eating disorders. David is a loving husband, father, and youngest of 9 in a Colombian American family. He owns Orozco Nutrition and hosts the One Small Bite podcast. He is an author, speaker, and registered dietitian nutritionist. David is a certified intuitive eating counselor, exercise physiologist, and a Quit Smart smoking cessation counselor with extensive experience in corporate wellness. Welcome, David.
Welcome.
Hi, thank you. Thank you very much for having me.
Yeah, so I'm super excited to talk to you because I think there's a ton of focus right now on nutrition and healthy eating and all of that. So before we jump into the question, I actually want to learn a little bit about kind of what you do and what kind of your typical patient or client sort of looks like.
Well, as you know, I'm a registered dietitian nutritionist, and a lot of people have some confusion about those two because what's a dietitian, what's a nutritionist? So I quickly tell people that a dietitian is trained. So we have to have an entry level of a master's degree with a supervised practice or an internship. We sit for national boards, and then we have licensure in each one of our states. Whereas a nutritionist could be anybody. Personal trainers, quacks on TV, doctors that are tired of being doctors, no offense. But yeah, so a lot of people can call themselves nutritionists, and that's an unfortunate circumstance that we have in our profession. Excuse me. My typical client so I've been in practice now for almost 17 years. My typical client was really adults that were dealing with weight concerns. And I don't want to go too much into the weeds with that, but early on in my practice, I help people try to lose weight. I don't do that anymore. I practice from a weight inclusive, a weight neutral, body positive, health at every size approach. And happy to answer any questions about that. But again, I don't want to go too deep into that. And so now eating disorders is just something that I see so much of. And again, I know we're going to get into a little bit of this, but with the advent of the pandemic, political and civil complications in our society, social media, I've definitely seen a huge increase in the referrals for kids, teens, and young adults with disordered eating disorder. And that's a good number of my clients right now too.
So that's interesting. I would probably echo that as a general pediatrician, I am at least recognizing eating disorders, I think a little bit more frequently over the last couple of years. And I think that's probably for a multitude of reasons. Sometimes even that label can be very upsetting for parents, right? When I bring it up and I'm like, hey, I'm concerned this might be an eating disorder, that doesn't always go so well for me. So maybe let's define a little bit of what that is and what is actually eating disorder. Maybe what are some common types of eating disorders? Because I think there's probably some misconceptions around this.
That's a good question. So first and foremost, an eating disorder is a serious mental health condition, and it can lead to both medical as well as mental complications. There are very strict criteria that are defined by the DSM-5, the Diagnostic and Statistical Manual of Mental Disorders. And the reason that's used to as the criteria is because it's a mental health disorder. And so with that said, it is a serious condition, but it is treatable. Again, it has far-reaching effects. It meets all genders, non-binary, binary, people who have transitioned, ages, races, religions, ethnicities, body shapes, and sizes. So it doesn't matter. It runs the gamut. And I say all of that because it's very important. We can easily think of eating disorders and see this white, thin, emaciated-looking blonde or brown brunette woman.
Yeah, always a female, right?
Always a female.
That's that's the archetype for sure.
Right, and it's not the case. It's just not the case. I currently am seeing 6 boys with eating disorders. So it is an unfortunate circumstance that reaches all people. As far as the question about the types of disorders, the DSM-5 has very distinct categories, very distinct types. I'm only going to name a few of them because they're the most common ones. And I'm not going to get into too much of the details of the less common ones, but probably the one everybody knows about is anorexia nervosa. And then the other one is bulimia nervosa. The other one that's becoming a little bit more common is binge eating disorder. And then there's also ARFID. And ARFID is very important, especially for your audience, because ARFID is probably something that happens a lot to boys, more so than girls. So ARFID, by the way, stands for Avoidant Restricted Food Intake Disorder. Let me give you a little bit of background of each one because I think it helps to kind of frame the types. Sure. Before I go do that, though, there is something called OSFED. OSFED is Other Specified Feeding or Eating Disorder. And then there's UFED, which is Unspecified Feeding or Eating Disorder. The two of them are very similar in that essentially we don't know that there is a specific criteria for any one of the other eating disorders, so they kind of get clumped into that. And then there's pica, ruminant disorder. Binge eating disorder, I often find to be a bit discriminative because a lot of people assume that binge eating disorder happens to people in large bodies, but that's not necessarily the case. I see binge eating disorder problems in men, as much as in women, but it's mostly diagnosed in women. And usually it's in women in large body. And that's what I mean about it being very discriminative. Anorexia is categorized by thin body. So there is a BMI, which I do not like using BMI, but it has to be used in this situation.
I feel like most nutritionists and registered dietitians, and I think even now doctors are kind of trying to get away from BMI. I've talked to people about this, and even endocrinologists, and I think everyone's kind of like uncomfortable around it because we know it's so sometimes vague and arbitrary and really doesn't tell the whole story. So that's like the logical side of me, and then like the I really need number side of me says like, oh, but like it's a number and we need to cling to a number, and that's probably I think why it ends up still being included in a lot of the diagnostic criteria.
Well, and the treatment programs for people with anorexia or bulimia is often hinged on that weight, and it is the single greatest marker of nutrition rehabilitation. And but there are others, and so that's why we cling on to that number quite a bit in that area, unfortunately. But there's a lot of atypical processes or atypical conditions that are also common in anorexia or bulimia, where I mean it's not the typical thin 15 or 16 BMI type situation.
I think that's really important. It sounds like that's kind of like the theme with all of this is like what you think this looks like. It doesn't necessarily look like that. And that's probably the biggest barrier for me when I bring these up with parents where I'm like, suspecting that we're dealing with an eating disorder. The initial pushback I get is like, well, it can't be that. Like, look at her or like, look at him, right? Look at the child. They're not necessarily somebody who looks like they have an eating disorder. So yeah. I do find that there's still a lot of misconceptions around what this actually looks like.
Yeah. And so anorexia is essentially characterized mainly by this restrictive, avoidant type of behavior. It's very emotional. It's very driven by perfectionism and control. And so they try to control you through calories or excessive exercise. And it's also very body-based. So body image is a very, very major component. They can never see themselves as being enough in their body. And they're never thin enough. Bulimia is characterized with a purging circumstance. Generally speaking, it could be through vomiting, but it could also be through use of laxatives as well, or both. And bulimia is one of the most dangerous ones because, as a physician, you have a lot of problems when a lot of those acids are pushed up. It erodes your teeth. It messes up with your esophagus. And it just has a lot of other medical conditions that pop up.
Yeah, bulimia scares me because you can absolutely get a lot of electrolyte disturbances with all
Mhm.
that vomiting. And I
Mhm.
think the more severe, when I was working as a hospital pediatrician, the more severe cases of eating disorders that I saw were actually electrolyte disturbances that ended up coming in and needing to get admitted to the hospital, and needing IV fluids and stabilization. And then we start to worry about their heart and things like that. So bulimia makes me nervous.
Yeah, this is a question. I mean, I don't know if you can answer this or not, but my experience, I find that a lot of EDs or ERs tend to not actually be very good at seeing a lot of eating disorders in especially in kids or even adults. Is that your experience as well?
So really the standard of care, and I think you will talk about this as well, is having a multidisciplinary approach.
Yeah.
And what we know is when kids who have this, eating disorders that need treatment, the best treatment for that is a team approach. And that means having a physician who's going to manage the medical piece of this. It means having a registered dietitian who's familiar with eating disorders and can manage the nutritional piece of this. And it absolutely means having the appropriate mental health support. So unfortunately, hospitals, and not even all children's hospitals, have that kind of model in place. And so if you end up in an ER or a hospital that doesn't have those resources, sometimes that can be detrimental. Now, that's not to say that you shouldn't go to the ER if you're dealing with somebody who's unstable. But for the most part, when I'm taking care of a patient who I suspect has an eating disorder or even has a confirmed one, my priority is to get them plugged into that kind of model of care.
Yeah, I often tell a lot of my clients when they're dealing with some severe problems and they have to go to ER or ED, I tell them, hey, make sure that you let them know your history. I mean, it probably will be there, but it's extremely important that you do. But let me go further because I know that I don't want to derail our conversation. So ARFID is the other one. So avoidant restrictive food intake disorder. And there's 3 subtypes to that. But this one is where we really see no body image concerns, or usually not very strong body image. So this is a lot where people have problems because they are afraid to eat something, or because they're scared that they might throw it up, or there may be something traumatic that's evolved around the eating, or they may just also be at sort of this lackadaisical, meaning I don't want to eat that, and it can turn into more picky eating. So a lot of boys suffer from ARFID or picky eating. It starts out as picky eating. Not that picky eating is an eating disorder, but it can start off that way. And if there are other circumstances, what we call ACEs, adverse childhood experiences, it could lead into those kind of complications. With that all said, the mortality rate for people with eating disorders is about 6 times higher than that with people without eating disorders. So that's where I get really, really concerned about that. And people with anorexia nervosa, it has the highest mortality rate than any mental health disorder. So that's why it's so important that you're getting this information out.
Yeah, I think I try to use those powerful statistics whenever I bring up eating disorders with the family. And I find that sometimes backfires on me because they think I'm either, blowing it out of proportion, or they're like, oh yeah, that makes sense when when you really have someone who's emaciated and that typical child that you think of that has anorexia, but like this doesn't apply to my kid. So let's maybe start with like the parents and caregivers. How can parents and caregivers approach a conversation with, let's say, teenagers? Because that does tend to be the patient population that I'm mostly seeing this in. How can they approach those conversations in like a sensitive and effective way?
It's a really good question. I thought a lot about this, and I kept thinking about the various clients that I have. I've had many problems with parents. It is very, very, very challenging sometimes because it's like what you said, the parents can meet those statistical information or those numbers with sort of trepidation. They can look at it and just backfires on you. Yeah, it's not my child is kind of the mindset, right? Oh, that's not my child.
That doesn't apply to me, right?
Yeah. But so one of the things that I try to do with parents is I tell them, look, try to be transparent. Try to approach this with a transparent eye. Try to look at this by saying to the teenager or to the child that, hey, I'm really worried about this, and I want you to know that I've seen this in other kids, or I just want us to be sure that, we're talking about it. That of course doesn't always work. So other things that I talk to parents about is talking to and with the child versus at the child, and so that may sound a little, not realistic, but we don't realize as parents. I'm a parent of an 11-year-old girl, that sometimes I'm talking at her instead of I'm talking with her or to her. And you can see the switch in her face when I'm talking at her. I can say things like very judgmental, very critical, without really giving her the opportunity to feel or understand where she's coming from. And so that's what I mean by talking with a child or talking to a child. It's like you're recognizing their emotions. You're not discounting them. An example would be, oh, that doesn't hurt. Or, oh, it doesn't feel like that. Or, oh, come on, brush it off. As a boy, I grew up with a lot of that, right? Oh, you're not bleeding? No, don't worry about it. Or, boys don't cry. That kind of mentality. I think it's also really beneficial for parents to share their own struggles and challenges. I think our children see themselves through the eyes of their parents. And so that modeled behavior, one example is at the dinner table. So this is one of the things that I do with many of my clients. I tell them to try to sit down and have dinner. It's so interesting to me how many people don't have dinner together. And kids are eating, a brother or sister are eating their dinner at one time, and someone's eating another dinner at another time and in a room, and maybe they were watching TV, maybe they're on their tablets. It's so funny. So I tell them, hey, get into a routine of sitting down and having a meal together. It's going to be hard. It's going to be difficult. It's going to be rough. But I think that that's a really good part. And so an example, when we sit down in my house, is I'll talk about something that was challenging to me and how that made me feel without any preconceived expectations, meaning that it's not because I want my child to express that, but my daughter often will say, oh, that's interesting because what happened to me was. And it's so much better than saying, how did it go today? How was school? What happened in school today? You get, oh, great. So I think that when parents are often sharing their struggles and their challenges and their emotions, that can be very, very helpful for a child to be able to then open up themselves. And I also want to say that it also really depends on that traumatic and the relationship that a parent and child build up over time. And so some of these techniques, they'll fall flat because there's way too much history, and that needs to be untangled. And it's like you said a little while ago, that's why you need that multi-professional approach to the treatment.
So for sure it's complex, but I think in general, I love that parenting technique. And I've had other guests here on the podcast where we kind of talked about like resiliency and right, sort of unconditional parenting. We had a whole episode about it, and that advice sort of seems universal. That is a really good time to connect. And we know, even medically speaking, that there is benefit to having family dinners, having consistent family meals. Mm-hmm. It helps build attachment between families, and really helps solidify those relationships. So then when you do need to address, right, something that is uncomfortable, maybe like disordered eating, you have that underlying baseline relationship to kind of, fall back on. Whereas if you don't necessarily have anything to kind of now start trying to engage in these uncomfortable conversations, I think will be hugely challenging.
Absolutely. 100% agree.
So I actually want to switch gears a little bit, because you mentioned in the beginning that we're seeing, right, more eating disorders, or we're recognizing them more. And you mentioned social media. So I'm fascinated by how social media, I think, affects all areas of our life, as just like a human in society. And then as a pediatrician and a parent, I'm a little horrified about what social media is doing to children and childhood. So what role do you think social media kind of plays in eating disorders?
I think it plays a huge role, but I don't think it's the underlying or only factor to an eating disorder. Because again, remember, eating disorder is a mental health disorder. It's a mental health condition. And I believe that social media, what it has really done is it has amplified specifically the bullying or the comparison, the body image issues that have already been established in the United States for a long time. And so I think it's really more of a microphone or a bullhorn, if you will, more than anything else. It's like you also can criticize, judge, bully behind a iron curtain. You know, it's like nobody really knows, excuse me, nobody really knows. You can be discreet, you can be anonymous, and you know, you don't realize that a lot of people are listening to you. You know, it hurts. It really, really hurts. So that's kind of the way I see social media play out more than anything else. I also, to move away from social media, I also think that there has been a lot of and I mentioned this earlier, political separation, political division in our country. And that polarization has created also an amplification of bullying. And it has also led into deeper rooted unconscious biases and discrimination that is really just more echoed. It is stated by people who don't really know the foundation of where it's coming from. But just to give you an example, if I belong to a group and I feel like I fit into that group, I fit into that group because I'll say the same things as that group. I'll believe the same things as that group. I may not question that because there's a very strong belonging there. So I think that polarization that we're seeing in the United States and in other countries is really echoing some of the mental challenges that we're having. I also think that another one, and this is something that we are seeing a lot more. I am not the breadwinner of my household. My wife is. She actually has a position that allows us more of the comforts than my own practice does. And that's a 2 working parent household. And so it takes a village to raise a child. You know, one of the reasons why I had a very nice childhood is because my mother had help from my sisters, and I had older aunts and uncles, and I had our neighbors, and there were so many people involved in the raising of the child. Where, you know, now my mother stayed at home, my father worked full time, you know, and that's not the case. So that's another. And then another thing that I also see quite a bit is of course, the bullying that's been going on in general. You know, I've seen so much of that that pressure that's coming in schools, but it also comes from the old-fashioned media channels, Hollywood, TV. I don't know if you're familiar with the Fiji study. Are you familiar with that Fiji study?
No.
It was a really good study that was done in the late 80s and early 90s, and they looked at the advent of television in the Fiji Islands. Prior to 1985, the Fiji Islands didn't have TVs. And so they looked at body image and eating disorders in Fiji. And what they found is once television was around, after about 10 years, the percentage of people, especially girls, that had image problems with their body increased by like 70% almost.
Wow.
It was really high. And it just goes to show how insipid it is in our vernacular. We are even just not aware at a very subconscious level.
That's very powerful. And I mean, I just want to reinforce, right? So we're not blaming eating disorders or any mental health issue on like any one thing. Correct. But I think, right, social media and regular media and the normalization of bullying and hatred, all of that kind of is each like a drop in the bucket, and eventually the bucket is full. And that's kind of how I think we get to where we get with all sorts of disorders, but certainly eating disorders as well. Yeah. So as a general pediatrician, I'm all about prevention. So I love talking about like how do we fix it? But maybe let's take a step back and talk about prevention. How can parents help maybe themselves even, but certainly their kids and their families develop a healthy relationship with food and their body?
Well, I think it's like what you said. I think first and foremost, they've got to look at themselves. I couldn't tell you how many parents I work with that are sending me their kids, and I'm a bit in between a rock and a hard place, because on one hand, the parent wants to help the child, but they themselves don't have a very positive relationship with food or their body. So to give you an example, I have clients where the father makes the child or children work out in the morning. I have a father who makes them work out between 5:30 and 6 a.m. before they go to school, and they restrict the type of foods that they are allowed to eat. Mm-hmm. And this sort of happens on a spectrum. It's not like you get this intensity, right? Mommy dearest kind of approach. It's not like that. It can be. But often it comes into very subtle and unconscious ways, like junk food. When people use the word junk food, we immediately, all of us, know a form of junk food because it's been taught to us that food is bad. And when we do things like that, while I understand that it means high fat, high sugar, hyper palatable food, it creates a judgment, and that judgment creates a very negative relationship with food. So as difficult as it is, one of the reconciliations that we have to do as parents is to understand our own biases as well. And so that's what one first thing that I tell parents is, look at what you're saying and what you're doing. Do you feel like you have to fit in a certain body, or you have to look a certain way to belong or something? Because your children are only modeling your behavior. They model more what you do and say than they say. So
it sounds like the language there, I think, is very powerful, because what you're saying is even the word junk food, we shouldn't be using.
We shouldn't be using.
There's no bad food, right? Is that part of
Correct.
it? Like there's no good food, there's no bad food. It's neutral. It's food.
Correct.
Right. And
Correct.
then you develop and encourage habits that are healthy. Is that
sure? I mean, I could show you that from the good standpoint, right? Because it's unfair to pick on what would be considered the bad foods, right? Let's use the good foods and give you an example of how that is unhealthy also. So as a parent, if you'd say, you've got to eat your vegetables, okay? I get it. It's important as a parent to give their child vegetables. But depending on the age of the child, they're growing. Vegetables are not a great source of energy. They're just not. And a child is growing. And especially when the child is very active and they're outside playing or they're part of a sport or something like that, So if I say you have to eat your vegetables, I am also saying that you are not allowed to have junk food at the same time. It's like, how do I win? Or I'll give you another example is if I say that broccoli is good for you, I indirectly am insinuating that something else is not. And so it causes always a black and white or a pro and con or a war that constantly is going on. How can you make peace? How can you have peace when you're constantly judging food as good or bad, right? Now, don't get me wrong. I'm also not trying to say to parents, let your child eat all of the junk food or all of the bad food or all of the good food that they want. Because that just doesn't make sense. Obviously, you're not going to feel good. And we need to also guide our children. So that's really, really, really important, is to help guide our children. Another thing that I tell parents is, hey, let's also look at intuitive eating principles. Let's look at intuitive eating. Let's look at HAES, health at every size. That I think is very important. Let's also look at a weight neutral, weight inclusive, body positive approach, because we're not just trying to get a child to gain weight. What we're trying to get a child to do is to nourish themselves. But again, it goes back to the very first one. If you're not capable of nourishing yourself, then it gets really complicated.
So a lot of this sounds like it sounds like a ton of education, right? Parent education, but also then child education, because the idea is that you're listening to your body.
Yes.
And you're feeding your body, right, what it wants. You're not overfeeding it, right? You stop when you're full, but you also recognize when you're hungry, and really knowing what foods you need to make yourself feel the best.
Correct. Yes. You've got it. Absolutely right.
That's so hard.
It is so hard. It is so hard. You know, one of the hardest things too, though, is it's not just education, it's also experimentation. So education at first, and then I tell parents, all right, now get to do it and experiment with it. And so that's one of the harder parts, is to the experimentation part. It is my job as a dietitian to help interpret what's going on, especially around their eating, and then what that interpretation means in relationship to their food or to the food that they're eating. Another great resource that I would say I help a lot of parents is I direct them to the Ellen Satter Institute. I don't know if you're familiar with that. The Ellen Satter Institute has something that's really good. They have the Satter Division of Responsibility in Feeding. And essentially what that is that to dumb it down, and by no means is this the perfect definition of this, but it's a parent's job to provide. It's a child's job to choose.
I love that. So I love that idea. And that's one thing that I always tell parents. I feel so validated right now that it's being reinforced by a dietitian. So I always tell them this is the guidance, and my kids even hear me say this all the time. I choose what goes on the plate, and they choose how much of it they eat.
Yes. Now, with that said, there needs to be shared responsibility or shared experience.
Decision making. Yeah.
Yes. So you buy things that the child will like.
Okay.
And you buy things that the child needs. And so,
okay, but sometimes those are diametrically opposed, right? My child likes chicken nuggets, but my child needs vegetables.
Sure, of course. But I can argue that your child needs chicken nuggets and may want vegetables. And I know it sounds weird because I can see your face in this, but the important thing here is that a child will choose on their own. Let me give you an example of what I mean. If I put vegetables on a plate with their meal, the child now no longer has the choice. Okay?
Yeah.
We do what's called a deconstructed salad at dinner time a lot of times. So what my wife and I will do, well, I cook a lot because my wife works so much, but I have the luxury of working from home. But what I do is I just chop up a whole bunch of vegetables: peppers, cucumbers, carrots, tomatoes, olives, nuts, and then something else. Oh, and I will put either kale or we'll put spinach or something. And we'll lay it out on a long plate, and we put it out in the middle of the table. And then we serve whatever is for dinner. Let's say it's chicken nuggets. We'll serve chicken nuggets from time to time. And then we might serve a carb like a pasta or a rice or something. And then each one of us will just put our hands on top of the vegetable plate and grab whatever we want. And that is so much more powerful than saying eat your vegetables on your plate. Because now the color looks so interesting, and a child can choose whatever they want. Now, this is harder as the child gets older and there's been a lot of history of fighting between the child and the parent, right? But I think that is a much better approach. And what I mean by letting the child be involved in the decision process. And so if chicken nugget it is, chicken nugget it is. The other thing that I tell parents is this is really a problem of quantity and frequency. Look, the problem with candy, gum, food that is hyperpalatable, very high in sugar, high in salt, high in fat, is not a problem in it of itself. It's a problem of quantity and frequency. And that is where the relationship comes in, and that's the undoing that we have.
So you're not saying shut it all down. You're not saying no chips, no candy, no gum, right?
Correct.
Vegetables all day long. That's not what you're saying. And I think that's really important for parents to hear. That we're not saying shut it all down, but we need to regulate the frequency, right?
Right.
And quantity.
And yes, absolutely. And it's okay for parents to regulate as long as the child is involved in it. And this is going back to the transparency. Hey, I know it's sometimes hard and you want to sit down and just eat all of this, so I'm only going to have a little bit of it. But then as soon as you come home from school, you got to get on your homework.
Right.
Right.
I want to point out that this is important, and it's very hard. And I just want to validate the feeling that parents who are listening to this, or parents who I talked to about this, are like, oh, this sounds like so much work. That it is a lot of work, right?
It is, yes.
Yeah.
Yes.
But it's very, very worthwhile, because developing this healthy relationship with food, developing intuitive eating habits, and really feeling good about what you're putting in your body is ultimately really going to pay off in the long run.
Yes, 100%. I couldn't agree more. And the earlier you start helping your child with any eating condition that they might have, the better, because it is a very long process. It's a very long process. It also gets harder the more entrenched they are in the disorder. And
it's harder to unravel. It's harder to put up the work up front when you can. And that probably means I would say even when you're starting to introduce solids, like to babies, right?
Yes.
This is where that concept starts, and we actually had one of my first podcast seasons, we had another fellow pediatricians, and we talked about healthy eating, and she echoed all the same sentiments that you're saying, but like right at the toddler level of like continuing to offer the food, and we don't force the food, and right, drama free, right, meal time, because once you have that dysfunction in place, it's much harder to unravel than if you just put the work in up front.
Yeah, and just to quickly speak on the treatment approach when a child is actually diagnosed with an eating disorder, I want to tell parents, because this is very, very important, there's going to be an incredible amount of resistance from both the parent and the child to seek a higher level of care. And this is really, really hard, without a doubt, and I do not discount the difficulty that entering into a treatment facility program can be. But gosh, the problem that I see is that oftentimes it's not done soon enough.
Yeah,
and they try to piecemeal by seeing a dietitian, seeing a therapist, seeing a physician, and that's the lowest level of treatment. It is a treatment, but it's the lowest level of treatment. And sometimes the disorder could be so entrenched in the child, could be so worked into their daily activity, that unraveling that at an outpatient type of approach is incredibly tricky, and it could actually be much more triggering and much more difficult. So I often tell parents, hey, brace yourselves. You're probably going to need to really look into a treatment program instead of trying to piecemeal. The other problem, though, is I'm also very keenly aware is that these treatment programs can be very expensive.
Yeah, and hard to find and get into.
And insurance sucks.
Yeah, insurance is a nightmare with it.
Yes, yes, absolutely. So I'm keenly aware of all of that. It's not easy. Right.
Agreed. Listen, we started talking about eating disorders. We ended with eating disorders. We covered a whole lot of ground in between, which I love. Any kind of last words or any main takeaways that you really want to make sure we address?
Yeah, if you see any issues coming up with your child around food, you really want to address it as soon as you possibly can in a transparent, in an open, in a shared way. But I'd also very much would recommend seeking out professionals, someone who's an expert in eating disorder, a physician, a pediatrician, a registered dietitian nutritionist, and or a therapist. And of course, a therapist is very much involved in all of this as well.
Agreed. Great advice. Well, I want to thank you so much. This was, I think, such a powerful episode, an important one, very topical right now. And I learned so much.
Thank you. I absolutely really enjoyed doing this, and I'm glad that this message is getting out there.
Make sure you like us on Facebook and follow us on Instagram and Twitter. Thank you for joining us on Kids Doc Talk.